Today, CMC and the Center for Community Solutions presents in the series Spotlight on Public Policy, our forum, Perspectives on Medicaid. Please help me recognize new sponsor, Buckeye Health Plan, represented by Joe Glass and Lynn Lyon for their support. And please help me welcome the Center for Community Solutions Director of Public Policy, John Honeck, to the stage to introduce our speakers. Thank you, John.
Good afternoon. My name is John Honeck. I'm the Edward D. and Dorothy E. Lined Fellow and Director of Public Policy and Advocacy at the Center for Community Solutions. Thank you for joining us today as we look forward to an insightful conversation. The Center for Community Solutions is pleased to support the mission of the Columbus Metropolitan Club to present people and ideas for community conversation. It is my pleasure to welcome you to the Center for Community Solutions' 72nd Annual Human Service Institute Eugene H. Friedheim Lecture. The Center for Community Solutions is a nonpartisan think tank with offices in Cleveland and Columbus. We focus on addressing health, social, and economic issues affecting our state. For over 100 years, we have provided strategic leadership and organized community resources to help find solutions to important public policy issues. We accomplish this through applied demographic research, nonpartisan policy analysis, advocacy, and communication. At this time, I would like to thank our 2014 Human Service Institute sponsors, the Third Federal Foundation, the Nordson Corporation, and the Sherwick Fund of the Cleveland Foundation. The Center for Community Solutions is very excited about our partnership with the Columbus Metropolitan Club. We welcome opportunities such as this to encourage stimulating discussions of how public policy affects people in Ohio. Today's forum on the Medicaid program will shed light on one of the most important public policy issues facing our state, one that is sure to be a topic of discussion through next year's budget process and beyond. Again, our thanks to the Metropolitan Club and to all of you for attending today. Now I would like to introduce today's speakers. Immediately to my right, Rea S. Hederman, Jr., Executive Vice President and Chief Operating Officer of the Buckeye Institute. James Misak, MD, Associate Director of Family Health at Metro Health. And also for the far right, Ted Wymyslo, MD, Chief Medical Officer of the Ohio Association of Community Health Centers and former Director of the Ohio Department of Health. Carrie, the podium, and our moderator, Carrie Ghosh, healthcare reporter, Business First of Columbus. Carrie, the podium is yours. Please help me welcome all of our speakers.
Hello. So standing up here at the podium, I'm reminded that every time I wear these nice shoes, I swear at the end of the day I'm never wearing these shoes again. In much a similar vein, every time I read a news story about Ohio's Medicaid program, I swear, never again. You ask a simple question, how much do we spend on Medicaid? Who's covered? What's the split between the federal government and the state government managing it? Kind of leaves your brain like a wrung-out washcloth. And yet here you all are, eager to learn more, so God love you. So we have an audience. I know about half of you are from health plans or from hospitals, so you know most of this already, but I'm going to give a brief overview anyway. As of August, we have 2.8 million enrollees in Medicaid. That is 24% of Ohio's population, and it was 19% just about 3 years ago. About 60% of enrollees are children, but the reason a lot of you are here and interested is the 368,000 who have enrolled under the expanded eligibility made possible by the Affordable Care Act Medicaid expansion, raising, it's one of those, who was added, it's one of those questions of, well, it was single adults and parents before it was 90%, now it's everyone at 130%, 138% of poverty and below who are adults, as well as the original population. So for the state budget, Ohio expects to spend $24.5 billion on Medicaid. That is combined, all funds, federal and state. About $1.9 billion of that is projected to be due to this expansion population, all of that from the federal government under the Affordable Care Act. Ohio's share of that expense is $5.8 billion, and it's 19% of all general revenue funds for the state. It's the single largest payer for all health care. Still with me? You must have comfortable shoes. So, for our panelists, we know that the reason Medicaid was expanded was not a smooth path. Took a Supreme Court case, made it optional for the states. We had a governor who said, let's take the option. A General Assembly said, let's not. And in October 2013, there was a unique legislative maneuver to have the State Controlling Board, which is a small legislative body, enact the expansion simply by saying Ohio will accept and appropriate this $2.6 billion over 18 months to allow this to happen. That expires with the next budget. Even if it had been part of the budget, it would have expired in the next budget. So we have a putative incoming Speaker of the House who was one of the guys they removed from the controlling board to make this happen. So I wouldn't expect an easy path to renewing this authorization. So you're getting your test run for your testimony before a House Budget Committee, but they're only giving you 90 seconds. So should Ohio continue the Medicaid expansion, and what other reforms should be enacted in the Medicaid program? Let's start with Dr. Wymyslo.
Okay, thank you. Well, let's make this simple. Yes. Okay. Next speaker. No, just kidding.
But why?
So the United Health Foundation, in their last release of state health rankings, pointed out that Ohio is a clean 40th worst state in the nation for overall health parameters that they measure for quality. Now, if you're like me, you're going, how can that be? We've got 7 huge academic medical institutions training physicians. We've got many nursing and other training institutions out there putting out tremendous resources. But the problem is that what we're producing is a continuation of our old fragmented healthcare delivery system that we've had in the past. Many providers are providing care to people that have resources, but they're not doing it together, talking to each other. Those that don't have resources are getting episodic, disconnected, not always best quality care in various different sites. We need to do something to change the system in Ohio. And the only way you can change the system is to start being able to aggregate the data and know what's happening with the population. That's 11.5 million Ohioans. So this is a part of a much bigger picture and a much bigger problem that the state's trying to address. One way to bring into focus the people that are disconnected and out of focus and can't be tracked is to get our uninsured into a position where we actually know who they are, where they are, and give them access at least to a way of tracking them so that we can start making changes happen in their lives, being more proactive, more preventive in our focus, being more population health focused in the way that we manage that population instead of letting them go around randomly to various ports that they ultimately find for care and always done at a late point in their illness and many times incurring preventable suffering that they don't have to experience if they're in a coordinated system. So Ohio's on a journey right now to coordinated health care, and bringing this population into alignment with the rest of our changes that are coordinating the fragmented system into a coordinated model is part of the master plan. You have to have a bigger plan than just Medicaid, and this is fitting nicely into the global plan the state has for getting at being 40th. We don't like it. We don't need to be 40th, and we shouldn't be 40th, and I hope no one's happy about that. So my hope is that this would be seen as part of a transformation of health statewide.
Dr. Misak, you get to speak for all Ohio hospitals right now.
Well, I think that going forward, both how health care is delivered and how health care is paid for is going to be increasingly judged by the triple aim. Better health for populations, better care for individuals, and lower total costs of care. Based on our experience at Metro Health with early Medicaid expansion, we achieved the triple aim, and I think it's time that we continue to go forward. We can't go back at this point. The triple aim is achievable. It's achievable with Medicaid. We've done it. I'll be talking about that. And the state can do it with Medicaid as well.
Great. I think there are three great points why we should be wary about expanding Medicaid. I think, first of all, as much as Metro Health may say they're saving money, we have a variety of empirical evidence saying expanding population to Medicaid is not saving money, and even worse, is not really improving health outcomes, what we care about. We know the greatest natural experiment, the Oregon Medicaid trials, turns out increased utilization of emergency rooms and did not result in better health care. And that's even the more optimistic study. There are other academic studies from like the University of Virginia that says Medicaid can result in worse outcomes. So Medicaid is a flawed program because it's an expensive program that has problem getting people who are on it access to care. Just this week, Robert Perry of the New York Times came out and said Medicaid beneficiaries are having problems getting access to the providers they need. And let's remember, this is the golden age of Obamacare, because next year the bad medicine of the Affordable Care Act starts coming in. Bonus providers to Medicaid primary care physicians goes down, risk corridors are up, productivity cuts to other hospitals and Medicare all start taking effect. So we're going to be paying for our spinach. So I think the first thing is to say, are we getting the care for the money that we need? The second thing I think is that in the vein of I told you so, the Buckeye Institute warned that some of the funding for Medicaid was based on some problematic estimates. One of the estimates was that we could tax Medicaid providers and then use that money basically to get more funding from the federal government to be able to pay for Medicaid expansion and make our providers whole. Well, it turns out every state's doing the same thing, and this has brought down the crackdown of the federal government as we warned. In fact, Carrie had an article on this just a few weeks ago. And what's happened is that Pennsylvania, you basically tried to do the same thing, tax providers to pay for more care to get more money from the federal government. The Office of the Inspector General of the Center for Medicaid and Medicare Services in Washington said, no, that's not really good. Pennsylvania said, but all our friends are doing it like Ohio. And just like when I tried that trick with my mom, that didn't work with the federal government. And the federal government has now issued a warning from the Office of the Inspector General saying these types of financing techniques should not be allowed. And so the question is the federal government going to take away one of the major funding streams? Finally, we also did, it unfortunately has a standpoint that more and more economic research is coming out saying expanded Medicaid does have the economic consequence of lowering your labor force. And indeed, we have seen the same aspects in Ohio. So we're looking at how do you pay for a costly program that can be effective, although there's a variety of economic research that says it's not. And at the same aspect, recognizing that this is going to put the state under a fiscal distress, at the same point, lowering the labor force participation, as we've seen in Ohio for the last 9 months.
Follow up on that. What do you mean by labor force participation? Because the argument is usually that if people are insured, they're better able to go to work.
Well, that's not the argument that the Congressional Budget Office made. If you remember reading the Congressional Budget Office's report on the Affordable Care Act, they found that people drop out of the labor force, about 1 million people, because they have health insurance. We know that when people get more benefits, you have strong work and disincentives in place. A new study from the National Bureau of Economic Research found that Medicaid expansion lowers working force participation by about 500,000 people. So, it's pretty much what you'd expect for those of us, if you've ever read economic studies, you give people more benefits, you see a less regard for work. People are making a very rational decision, and that has economic consequences on the state, which is why I think if you're going to look at expanding Medicaid, you want to make sure you're attaching, workforce requirements, going back to President Clinton's welfare expansion, saying if we're going to have a benefit, we need to make sure we're tied to work so people remain in the labor market.
And one other from the beginning of your remarks is Medicaid is federally funded, has federal oversight, but is administered at the state level. So should Ohio make Ohio's decisions based on experiences in Oregon?
I think you need to take a look at the evidence to make prudent decisions. It's not just Oregon. I think Wisconsin and Massachusetts is also seeing that, when you expand services, you get an increase in utilization. So, you want to take best practice, you want to take lessons in saying the idea that expanding this is going to lower prices. And I think finally, let's take a note that John Gruber, the economic architect of the Affordable Care Act, said in the Washington Post, this bill is not going to lower cost. This bill is all about coverage expansion. So whatever we think about Medicaid expansion, let's realize that we are on the start of the journey about how to make this a physically sustainable program for the state. We know that expanding to an unserved population is simply about coverage and not about controlling cost. And that question is going to be on the table for this governor and the governor following him and the governor following him, unless we can look at making some changes now. And I think the important thing about the reauthorization is it gives Ohio some leverage to be able to renegotiate with the federal government, be able to make some opportunities from reform that we've seen other governors like Mike Pence take to be able to push for more waivers from the federal government to be able to experiment at the state level to move for a more effective Medicaid program.
Thank you. Dr. Misak, you have a unique perspective among Ohio hospitals. There's only about 9 months of data on the Medicaid expansion as a whole, but Metro Health had a head start under a federal waiver. It was $100 million, two-thirds of that from the federal government, for Metro Health Care Plus, kind of a proto-Medicaid expansion program, started 10 months earlier than the rest of the expansion, February 2013. The last patients were transferred over to Medicaid this April. There's 28,000 patients in total. How did that go? Did it result in increased utilization, or did it lower costs?
The Metro Health Care program was a success at achieving the triple aim. We enrolled over 35,000 unique individuals during the 9 months of the program. 28,000 were enrolled at the end of 2013. Of these, 23,000 had selected a primary care provider. They were cared for in our system of primary care patient-centered medical homes where their care was coordinated throughout the system. They had access to prescription drug coverage, and the average utilization of prescription drugs per patient was close to 5, which says something about the burden of chronic disease on this population and how important access to medications were in treating those illnesses. What we found is that our Care Plus patients with diabetes who receive care in the Metro Health system achieve significantly greater improvements in both the quality of care received and in the outcomes of that care. And this was all done at a cost that was 25% lower than the CMS budget neutrality cap that was given for the program. So in terms of better health, better care, and lower costs, Care Plus was a success.
Dr. Wymyslo, you joined, former health director, you all know him. You joined the Center for Community Health Centers, which is the federally qualified health centers, generally free or low-cost clinics in urban and rural environments, specifically with a mission to help adopt patient-centered medical homes at these clinics. So how does that relate to the use of Medicaid? Does Medicaid managed care support and accommodate this model?
So we saw what happened in Massachusetts when they gave everyone an insurance card. That was not a solution that anyone was looking for, and Oregon kind of repeated that experiment by giving people access to care but not directing them to a coordinated care delivery model. And we already know our system doesn't work now. It's the most expensive in the world, so why would we want to reproduce that? So I'm in total agreement with Ray on the perspective, and some of the information from some of those studies demonstrates that you don't want to do expansion unless you have somewhere to put people where they can actually manage their health better than we've done it in the past. That's where patient-centered medical home coordinated care models come in, and the federally qualified health centers were largely built around that philosophy. And so for us in the state of Ohio, we now, of our 206 sites, 72 of those are patient-centered medical homes. So a third of ours are. Now, if you look statewide at how many practices in primary care are, it's only about 8 or 9%, but they're moving up quick. We have about 530 patient-centered medical homes in the state. We wanted to build up the state's capacity before we did the expansion, right? Because I didn't want to put people into the disjointed care models, the fragmented care models that many of you are experiencing now. Because having insurance doesn't mean you're getting good care, right, gang? I hope you all know most of you aren't getting very good care. And so do not, and what I do to the public is I say, do not be satisfied with what you're receiving right now. If it is not coordinated care that's modernized and it's an enhanced model, then find someone who will give you that. Don't keep putting up with mediocre care. That's why we're 40th in the nation. We've got to all, I think, take responsibility for us, our families, and our friends to get them into better models. So we're putting Medicaid patients now, who used to be uninsured, into structured systems of care. We can track data, we can look at outcomes, we can be able to tell you, are we achieving our goals, and we can also look at cost and say, now let's look at the value equation. Am I getting to high quality outcomes and doing it for an affordable cost? That's called sustainable care, and that's what we're missing right now. That's why the country as a whole has such a high percentage of its GNP related to what they're expending for health care. And we've got to stop that in Ohio because we can't afford Medicaid to go out of control either, the way that it has in the past. So we've changed the model to an expansion type way of approaching this, but we didn't do that until we had the capacity in our system to take these patients on. The reality in federally qualified health centers was about 35 to 40% of our patients were uninsured. So those people now have been converted into Medicaid patients. They're in a home already, and we're going to continue that, and we're bringing others into the ranks now that now do have coverage. That means I can work in a preventive way with them to try to prevent chronic disease, which is really the opponent you're trying to tackle here. Obesity leading to diabetes, hypertension unmanaged leading to coronary artery disease, congestive heart failure. These other things that we as a state are struggling with, we've got to get under control, but we got to start earlier up the pipeline. That will happen now that we have access to care for some of our most vulnerable citizens in Ohio.
On a budgetary level, having patients on Medicaid allows you to hire more staff, have greater capacity than having uninsured patients because some payment is better than none?
Right. We're redirecting those funds now. For instance, our latest addition in federally qualified health centers is optometry services. So not only do we want people to be healthier so they're better employees and employable, but it's important to be able to see well, right? To be employed and also to read and to do other things if you're wanting to better your position. We're trying to get people to be able to realize their potential that they have in their lives by helping them experience better health. And we're convinced that having them in an organized system where we can know who our patients are, who's attributed to us, and then follow them along to reach their personal plans of care that we set for them to make sure that they achieve the goals that we set for their health means that we will predictably have a population that's able to achieve its personal potential, but also for business, you're going to have a population that for you is more productive. So we get at the absenteeism, we get improved presenteeism with that, but most of that want employability for this population, and many of them have health problems that keep them from being employed.
Mr. Hederman, should the battle get too heated, if Governor Kasich is reelected, the controlling board gambit could be employed again, but only for 1 year, because the 100% federal match goes away in fiscal 2016. Do you believe that the programs you're hearing described here, plus the general move to managed care and Medicaid, can bring costs down enough that Ohio can afford picking up its greater share of the match, and it increases over time?
I think Ted's done a great job outlining, why managed care, and I think Ohio has a great advantage that they have a healthy number of managed care plans, and that's the direction that we want to shift kind of Medicaid to, where you have competition between health plans, tracking the patient through with individual plans. We'd like to continue to tweak. I think we're not quite at 100% of managed care, but we're definitely over 50%, and we're going to keep moving in that direction. But I think, managed care is kind of a step in the right direction, but it's not going to get us all the way there. I think there's going to be ways to look at, and this is going to be involving segmenting your Medicaid population. I mean, most of what we're talking about today is going to be more your healthy single adults, because we know people on disability, the elderly, people that require long-term care have different needs than some of the expansion population that would be eligible for work. So we want to figure out what are the solutions we need to do that. And I don't think for some of these populations like the duals and the long-term care that simple managed care is going to be the end-all be-all. I think you're going to need to continue experimenting to get the savings that you need. And I think this experimentation is going to be led by the states, but also in partnership with the federal government. Because again, we're all focused on who's the expansion population, but your biggest drivers in Medicaid costs are going to be your duals, and then fastest growing segment is going to be your long-term care.
In an effort to make nice, the legislature did create a joint committee to study Medicaid and find other ways to increase the efficiency. So what are some things that the three of you would like to see come out of that panel, absent discussion of an expansion?
Well, I think it's absolutely critical that the state encourage Medicaid to pay for value rather than volume. I think that the fundamental shift that's going on in both how healthcare is being delivered and how healthcare is being paid for is a transition from paying for services to paying for value, paying for outcomes. It's incumbent on healthcare delivery systems to design themselves so that they can deliver value. We've done that at Metro Health. We've done that with the Care Plus program. We've shown that it can be done in the Medicaid expansion population. I think that the encouragement on the payer side needs to be towards driving towards those integrated delivery systems which can deliver value for both payers and better health for patients.
One thing I'm very intrigued about is the Indiana experiment with health savings accounts. I think a health savings account is another tool to be able to help patients with the providers pick the right care we need. I've seen some trial studies indicating that you do get good value for care with people being able to sit there and more effectively choose what treatments they want. I think being able to give more transparency both to providers and patients is very much key, where patients have an idea and say, who gives me the best care and at what price? I think that's an important aspect of any economic system. Is the same thing in medicine. So I think looking at how Indiana continues to experiment is something that we could draw upon. I think there are a few other things to be able to continue moving with the transparent model, and also making sure that simply because people have Medicaid, they may not have access to care. So looking at moving beyond at scope of need, a certificate of need, scope of practice, to be able to boost the access, the availability for people to seek out care they want, because care without really having a provider really isn't much use to a lot of people.
And my perspective is they need to realize they're on the Lewis and Clark expedition. That is, no one knows what the hell is going to happen when they get down the road, but what they've got to do is work together with people that are strange partners and bedfellows. So I'd like to work closely with Ray to make sure that whatever his concerns are, we work through that, because they're valid concerns that we need to overcome, but also to learn from the experiments that are going on. There's a lot of evidence accumulating about what not to do, and also some about what to do. And we've got to bring that together, and that's what I'd like them to do, is pull together the evidence so we can define the best route we know, realizing fully that whatever we devise won't work exactly right the way we planned it, but it can be corrected along the way as long as we have the right partners that we're working with. And that's key, is that all the partners are at the table helping. We've got to have insurance there. We've got to have the hospital health systems there. I'd better get the deans of the medical schools and nursing schools and everyone else there so we train people differently, right? But I really got to have the patients there, the population, all of you there, saying we demand better care than we're getting today, and we know we can fix this. Let us be a part of the solution, because I really don't like to fix stuff for people. I like to fix it with them, and I think they understand that. I mean, I believe that they really understand it. We have to now devise some milestones so we can tell, are we making progress, laying out the expectations clearly, but then have high accountability built into that, saying if you haven't reached the milestone, then we need to talk to other people to correct this, because we're not where we need to be.
And I think we need to recognize that Ohio is really uniquely positioned to achieve maximum value for its Medicaid dollar. Governor Kasich and the Office of Health Transformation have really emphasized both the expansion of patient-centered medical homes, which is something near and dear to both Dr. Wymyslo's and my heart, as well as episode-based payments that pay for an entire episode of care and then hold the providers accountable for delivering value for that care. Also, the state has a program called MedTap, the Medicaid Technical Assistance and Policy Program, that has a healthcare access initiative that is training multidisciplinary healthcare providers both to attract them and to retain them in serving the Medicaid population. We have a very active program at Metro Health that is doing just that, and that program so far has been showing great success in the early going. So Ohio has a lot of things happening that really position us well to take advantage of Medicaid going forward.
All right. In a couple of minutes here, we will be taking audience questions. It's not, it's not all about me. So please try to think of something. And in the meantime, I got some math for you. All right, Mr. Hederman, I'm going to ask you to start with this one. So we're going to make a person. We're talking about people and 2.8 million people and 380,000 people. What is 138% of the poverty level? For a single person, that's $16,105 annual income. That is, if you worked minimum wage, 40 hours a week, you would just surpass that by about $400. And we all know that there's not many minimum wage jobs that are really 40 hours a week. So let's take a 25-year-old male. He's a non-smoker because internet. And he would now qualify for Medicaid. If we retract the expansion, I checked some of the rate filings. We pick Anthem. They're one of the biggest sellers on the exchange. Their cheapest bronze plan, it costs $221 a month. That's about $2,650 a year. There's federal subsidies. It takes his cost down to $560, but it's a $6,000 deductible for our 25-year-old minimum wage, 35 hours a week worker. Medicaid spends on that male $223 a month. That's $2 more than the premium, zero out of pocket. So which of those two plans makes the most economic sense, and what's the better path out of poverty?
That's a great question, and near and dear to my heart, doing a lot of research on economic mobility. I think the first thing is that, again, differing between coverage and care. Because Medicaid would give you cheaper coverage, but will not result in the better care. And again, leaving aside my esteemed panelists, taking a look at other data from the rest of the nation, access to Medicaid, on average, has far less access to care as people with private health insurance. Most providers, many providers, are more likely to reject Medicaid than private health insurance. So if your idea is to try to get this person the right care he needs, then going with the Anthem plan would seem to make more sense. That doesn't mean that we sit there and say, he's got to pay for it all himself. There are ideas that have been moving in the free market movement about saying take money that could be spent on him and attach it to that individual and use that for like a refundable tax credit, refundable voucher, whatever you want to call it, on a sliding scale instead of a cliff effect to be able to do it. Going to your second part of your question is what's the best way to get this way out of poverty? The best way out of poverty is not complicated, is to be able to ensure people have a job. And so that ties into a whole bunch of basically programs you need to be able to do to be able to boost the economy. We've seen the unemployment rate fall, but that's unfortunately mostly because people have dropped out of the labor market instead of strong economic growth. So we need to take a strong look at what we can do at both the state and the federal level to jump up basically job creation.
You want to jump in?
Just to, if I could, break down some of the kind of preconceived notions about what Medicaid is. There are a lot of different ways Medicaid patients can receive care. That's why we've created the federally qualified health center system. We have 563,000 patients that we care for across Ohio. Over half of those are Medicaid. In our centers, a patient will not only be able to see their physician, nurse practitioner, PA, but most of our centers have dental that's embedded in there. We have pharmacies that are embedded in there with the pharmacist on site. We have social workers, dietitians, and now we have optometrists on site. Now, don't you wish you had that when you're getting your care? I mean, just think about it. Wouldn't you like to go to an office that has that? And they're all connected with each other electronically, so they know what each other's doing and share the same record, and they're connected with the community resources because almost all our centers are now fully electronic. So there's the old traditional Medicaid that you all stereotype in your mind, and then there's the new model that's out there. And we're working very hard with the FQHCs to spread them farther. We're in 55 counties out of the 88 counties in the state, but we're a model that can be duplicated, replicated in many communities, and we're finding communities want that to happen and are coming to the table, enhancing and improving the quality of care our Medicaid patients have available to them. So that's the old model that I think we're all left with about Medicaid. I'm saying it's not that way anymore. It doesn't have to be that way in many communities. And if it's that way in your community, what I say is do something about it. Help improve access to high quality care for Medicaid patients in your community. And while you're at it, get better care for yourself. That's right.
Add a few years to your hypothetical patient, and he becomes my real patient, Bob. Bob is in his 40s. He went to a local emergency room a couple of years, but it's about a year ago. At the time, he was working a minimum wage job, was uninsured. He went to a local emergency room for a cough. They did a chest x-ray, and they found a spot on his lung and encouraged him to get that followed up. Well, Bob didn't have any health insurance, and he was afraid of the costs, so he chose not to do that. He continued to work, continued to take care of his family. He was a single father. Bob enrolled in Care Plus, and he came to me, and he told me this story. And because of Care Plus, I was able to get the tests he needed. Unfortunately, Bob was diagnosed with lung cancer, but it was at an early stage where treatment can lead to cure. If Bob were in a bronze plan with a $6,000 deductible, Bob would have been in exactly the same place he was in that emergency room a year ago. We can't go back to that. My patients can't go back to that.
With that, anybody want to give it a go? Now, I'm supposed to say this official stuff. It is CMC's tradition to take audience questions. Please go to the microphone. Please state your name and ask your question. We thank you in advance for avoiding editorial comments. Is it just the one microphone? There you go.
Hi, I'm Meg Tieford. There are just two terms that you used, and I'm not sure everyone in the audience knows what they mean. A medical home, because it's not actually a physical building as I understand it, and then duals. People at my table are saying, who are the duals? So if you can just say what these terms mean, I think it would be helpful.
That's these white hairs over here.
Well, I'm going to do the first one because it's easier, I think. Patient-centered medical home is not a home. What it's home to is all the information about your health that is in existence anywhere around. And so it tends to be the central repository or home to everything that's known about your health from all the providers who take care of you. It's patient-centered in that every decision that's made there has your interests first, the patient's interests first, before the center. So they've enhanced access with evening hours, weekend hours, and 24/7 capability for reaching the center. You can't get a recording when you call that says we're closed and call on Monday morning when we open again or go to the emergency room. It's also got enhanced communication capabilities so that it's connected to the community, the emergency room, the hospitals, many of the other providers in the community, so they can coordinate care. Because care coordination is the core, most important principle that makes a patient-centered medical home a medical home. They basically know and understand all the points of contact for patients for their health in the community and help patients make good decisions about their health, hopefully before they're ill, and have a prevention focus too. Team-based care is found in the medical home setting so that instead of the physician being totally responsible for everything that happens to you, we use other disciplines who have greater skills in many areas to help us collectively manage your comprehensive health needs, not try to be everything to everyone myself. So that's where we're embracing other clinicians like dentists, social workers, dietitians, and others to get at your total health needs, but do it with a team who's engaged in that. So, but it's not a physical home, you're correct. It's more of a term that's used to indicate that ultimately every bit of information about you is known by and coordinated through your home base.
Oh, I get dual eligibles?
Well, I did my part.
At a simplest term, dual eligibles are people that are Medicaid beneficiaries. They're also Medicare beneficiaries. They make up about 15% of the Medicaid population and about 40% of total Medicaid spending. And it's a very complicated formula about what part of spending is covered by Medicaid and what part is covered by Medicare, which probably will not serve any of us well to go down that rabbit hole. But the important part is that's a very small portion of the Medicaid total population, but is by far and away the largest driver of Medicaid spending on a per capita basis.
A quick follow-up on medical homes. This is always the theory, you know, that better coordination will prevent. Is it working? Is it really working in practice? Do we have the IT support? Do you have, you know, are the plans, the care coordinators, are they helping with this effort or getting in the way? Are people actually getting enrolled and placed with the care coordinator? Is it really happening?
Yes, 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 and yes at Metro Health. And I would invite anyone who would like to see patient-centered medical homes in practice in the context of an integrated delivery system with a very sophisticated electronic medical record, come on up to Metro Health and we'll be glad to show you our system. We are an example of how it can be done, and I would argue how it must be done going forward. Dr. Wymyslo outlined the elements of a patient-centered medical homes, but medical homes exist in medical neighborhoods. And the medical neighborhood is responsible for delivering on the triple aim as much as the medical home is.
Our next audience member.
Hi, I'm Sherry Cheney-Jones with Measurement Resources. I think my question probably is primarily to Mr. Hederman. I had not heard the research results that showed that as Medicaid has been expanded, more people have dropped out of the workforce, so thank you, that was really interesting. I think that correlation really shocked me because the whole premise was that these individuals who were eligible for Medicaid expansion were working low-wage jobs. It didn't offer health care in the kind of initially. So is it true that people who had health care prior to Medicaid expansion are now dropping out of the workforce to take advantage of Medicaid to not work their job that had health care? I think that's my first question. My second question is, are these results published somewhere that we can take a look at?
Your last question, yes.
Okay.
I would take a look at, again, the Congressional Budget Office, when their main report on the Affordable Care Act, they looked at the employment effects, and they did say about 1 million people will drop out. There's been follow-up research. Craig Garthwaite and colleagues at National Bureau of Economic Research. I'll be glad to point you in that direction, looking directly at the Medicaid expansion. I think, part of what you're seeing is unfortunately, there's so much churn going on in the health insurance industry that I don't want to say anything that might be incorrect. I think you're seeing some crowded-out effects. You're seeing people moving in and out of the Medicaid system. And so we don't have a lot to tell, what's going on. I think, primarily a lot of these people that, covered minimum wage jobs, statistically speaking, a lot of them were already going to be eligible for some type of, single moms, for example, are already eligible for Medicaid in many states, depending on where you are on the percent of poverty line, maybe not Ohio. A lot of minimum wage workers are dependents with their family that were covered by other provisions. What you're seeing is you are going to see some basically people sitting there, is what the research has found, that people are dropping out.
Okay, thank you.
And just to comment on that is that, incentives are so important to all of us, right? I mean, we've got a population that needs to be incentivized quite often to do the right thing, and we want to make the right choice, the easy choice for people. And for some, the easy choice is not to work, right? And so if that's laid out that way, people will go that direction. And so what we want to do is take that information and use it to help us redefine what we currently have in place and correct some of the incentives that are there to not do what we'd like to see as outcomes, or they will keep happening. So it's really important we keep getting that research in and that information. You're asking what will that Joint Medicaid Oversight Committee do? My hope is that they will be the think tank that will take in data and information about all the experiments going on and seeing what works and what doesn't, and then realign incentives to produce the type behavior that we would all like to see happen.
Right. I mean, this goes back again to the 90s welfare model when Bill Clinton and everything worked with his Republican colleagues to say, look, let's reform welfare. We know that there's a great big work disincentive, and people are making the rational choice. So being able to take a look and say, how can we make sure that people who can work are not have perverse incentives to remain dependent on the federal government? And that's what these economic studies are really finding.
And I think that from where I sit as a physician, the primary locus of reform really needs to be the healthcare delivery system. The healthcare delivery system needs to reform so that it's delivering true value for the dollar and delivering on the triple aim.
Next question.
Hi, my name's Marie Trudeau. I'm with W.E. Davis Insurance, and thank you all for being here and sharing all this very interesting information. As a health insurance agent, I've spent many, many hours at healthcare.gov, more last year than I cared to, and hopefully next month in the open enrollment it won't be as bad. But I just wanted to clarify something that was said earlier. If someone's on there and they qualify for Medicaid, they don't have the option of getting a subsidy on a health care plan. It's just not there. You can't
My example was if Ohio didn't have the expansion, and therefore if he were shopping on the exchange in other universe.
Yeah, my point is he doesn't have an option. If you get kicked to Medicaid, you can't get the subsidy. But my question is, probably for the doctors, a lot of what you're talking about in terms of the healthcare has to do with lifestyle. It's not so much a medical problem as a lifestyle problem with obesity and smoking and things like that. I mean, how do you deal with that before it even gets to you?
Well, I think we can start with how we're not dealing with it well in our current fee-for-service system. No one, with the exception of very few people, no one is paid to have those conversations with patients to help them choose healthy lifestyles. What we're paid to do is provide services. And this is why payment reform, moving us from paying for services to paying for outcomes and value, is so critical, because then that becomes part of the conversation the healthcare team has with the patient. It's part of our orientation, it's part of our focus. So I don't think we get there without true payment reform, and I'll ask Dr. Wymyslo to comment on that.
Well, certainly, again, we're trying to incentivize behavior also to the clinicians, right? You want them to do the right thing. You'd like them to be intervening at times that can make the biggest lifestyle differences in patients' lives. My problem used to be if I coded for doing that, I didn't get any reimbursement, right? Because the insurance companies didn't recognize the value of prevention. So I'd have to make up diseases so I could get paid for taking care of diseases. And you could always find something wrong with someone. Yeah, there you go. Well, somebody's anxious or something. I come up with something that's codable, but really what I was trying, but maybe I'm being too transparent. I don't know.
Will the auditors please leave the room?
That's right. But in reality, the clinicians have known for years that we need to address lifestyles, because 70% of what people are going to die of in Ohio are preventable as far as lifestyle-related causes of death. I mean, you're ultimately going to die, right? But let's die of things when you're 100 that you can't avoid, not things at 50 that were totally avoidable if you would have lived a healthier life. So what we're trying to do, and like what Robert Wood Johnson Foundation is doing, is working with the entire nation saying, we need to adopt nationwide a culture of health. And that means everybody has to be focused on health. You have to be, I have to be, clinicians, hospitals, insurers. And that's a very different focus than we've had with our disease focus that we've had for healthcare in the past. That they expect will take 20 years to make a change in the way human beings who live in America to perceive their health experience. And so our practices are starting to align that way. Our organized practices that do coordinated care with care coordinators, they get it, they coach. We have health coaches, we have other components in place in some practices, but not all of them. So people like Office of Health Transformation and Medicaid and others understand we need to move in that direction, and they're trying to get a very bulky ship to change direction here. Well, we're plagued with cultural preceding conditions that we all every day kind of live. We live over and over the same rote life that we have in the past. We eat in the same places, we go to work the same ways, we do things the same ways, and changing that is the real focus right now of a new focus on health to get at population health in a way that we never have before when we chased individual diseases. So we're past chasing diseases, we're into more the global look, but we need insurers to be aligned with that.
So it looks like we have time for one last question from the audience.
Yes, Dr. Wymyslo, Delaney McDaniel from RX Consultant. You were saying that there were a multitude of healthcare providers that were giving input. What I would like to address is we have pharmacists that are available to look at the medication adherence piece, which currently is costing our healthcare system $350 billion a year from avoidable medication errors. It's also costing our healthcare system 125,000 lives as of December 2013. How is the medical-centered home going to address those issues with the Affordable Care Act, as it is one of the things that they're looking at outcomes with medication adherence?
Very good. Well, first of all, let me tell you that we certainly do appreciate the role of the pharmacist in the healthcare delivery system. And secondly, they've been underutilized, right? Which is why some of them weren't particularly happy, because they were trained way beyond what they were doing as a function. Now we're realizing they have a clinical role that goes way beyond their training, and they are being used in many of our sites, at least as far as federally qualified health centers, and I know they're also being built into some of the global collaboratives that are present in Cleveland, Columbus, and Cincinnati. We're getting the data from that because everyone's looking for an ROI on this. They want to know, is it worth the expenditure that we put forward? Do we get results and outcomes that are better than the cost? And what we're finding is good information on that. That is controlling meds, enhancing adherence, actually having people take their meds that we prescribe versus saving money by splitting pills in half and all those things. That makes a big difference in outcomes. And so when you look at total cost of care, remember I said data is going to be critically important. If we can get total cost of care data, that will show where the impact is greatest. And I'm certain pharmacists will have an expanded role as we move forward. It's getting the data together to prove that. That's your challenge right now and our goal right now. But I woke up this morning next to a pharmacist, so we're trying to see if we can't find better ways to get along, possibly.
Well, I think the data is out there. It's just a matter of, I think, us pharmacists getting out of the producer mindset of dispensing prescriptions, which everybody thinks that's all we do, and becoming the provider mindset. Speaking with pharmacists and a lot of my peers, how am I going to make money if I don't dispense prescriptions? I can't get anybody to change the mindset to become a provider and not to become a dispenser, which I'm not a dispenser. I don't work for a dispensing pharmacy. I'm not attached to an insurance company, and all I do is educate patients through the National Council of Patient Information and Education. Right. And that's, the full focus of my practice. And it's just educating patients is our focus.
Thank you.
We've hit our time limit, as fun as this is. So I am going to turn the podium back over to Kermit Whitfield.
Thank you very much. Great discussion today. I hope you enjoyed today's forum. We encourage you to continue the conversation in the lobby over coffee and cookies. Remember, you can view and share all of our forums on Columbus TV Channel 3, statewide on WOSU through the Ohio Channel, and anytime on CMC's website via YouTube. Once more, thanks to our sponsor, the Center for Community Solutions and Buckeye Health Plan. Also want to thank our speakers today, Ray Hederman, James Misak, Ted Wymyslo, and our moderator, Carrie Ghosh.